Hello and welcome to this Hero Learning Series webinar, a conversation about the Braidwood decision, health screenings, and the early detection of disease. I'm Erin Moseley, Hero President and CEO, and it's my pleasure to serve as your co-host today, along with Dr. Paul Terry, Hero Senior Fellow. A couple of housekeeping notes. Please do use the Q&A tool to submit your questions for the panelists. I'll be monitoring it throughout the hour, so don't wait until the end. And when you leave the webinar, please pause for a minute to answer the survey. We really do read them. As usual, we have an all-star cast of hero friends for today's webinar, so allow me a few brief introductions and we'll get right to the good stuff. Erin Seaverson is the Senior Director of Health Research at WebMD Health Services. She has published numerous peer-reviewed scientific research studies, and her work in research and reporting helps to define best practices for the industry. In fact, her research was recognized as Paper of the Year in 2019 by the American Journal of Health Promotion and as one of the 25 most important studies in workplace health promotion for its contributions to the industry. Erin earned her bachelor's degree in exercise and health science from Alma College and her Master of Public Health degree in epidemiology from the University of Massachusetts. Next, we have Rachel Mosher Henke, co-editor of Knowing Well, Being Well, the American Journal of Health Promotion, and Vice President of Evaluation, Economics, and Predictive Modeling at the Lewin Group. Her research has included evaluations of payer approaches to improve health and productivity with a focus on culture of health and value-based care models. Rachel has a PhD in health policy from Harvard University and is the proud recipient of the 2021 Hero Mark Dundon Research Award. And then we have Erin O'Malley, an attorney specializing in access to healthcare and healthy living. She currently manages federal regulatory affairs for the American Heart Association's Access to Care Issue Advocacy portfolio. Previously, Erin served in roles providing legal technical assistance and subject matter expert consulting to advocacy campaigns and government officials in federal government in all 50 states and in most major cities. Erin is active on 2 boards of directors for organizations supporting employment and education opportunities for the disability community. Erin O'Malley will start with you to help set the stage with the legal rulings. And for that, we will tee up our first poll question, which is: a Texas court ruled in favor of striking down part of the ACA's requirements. What is the reaction in your organization or those you work with? Are you aware or not? Please answer the poll. And Erin, it's all yours.
All right, I'm going to share my screen with slides.
Yep. And Erin, we're just going to go ahead and get your screen up, but we're going to launch these results in just a second, just for the audience to know, as we were convening this panel of experts on these questions of access to preventive services and the tension between legal and medical issues. We want to learn from you all during the coming hour, because this is a new enough issue that we're really not all that acquainted, nor has there been public polling about how acquainted most professionals, much less consumers, are to the implications of this court ruling. So we have a pretty good participation rate. I'd love to get up to 80%, so I'm just going to give you another moment or two to weigh in on this one, and then I'm going to go ahead and end this poll. So for all of us, especially Erin O'Malley, for you to see right up front, when how aware are you? We have 0% that are keenly aware and mobilizing for action at this point. 45% of those who are participating today, and this may well be a pretty biased, informed audience, Erin O'Malley, are discussing the decisions and deciding on action. But look at this, this is also what we anticipated. A full 50% are either aware of this decision but unlikely to act, or unaware, and they're really not discussing it in their organization. A full 50% are either aware of and unlikely to act, or unaware and not discussing. I think it's safe to say, Erin O'Malley, that you and I would love to change those numbers just a tad. We would love to move them in the direction of thinking about what the private sector needs to be doing to influence this kind of decision making. So at that point, I'll stop sharing, and then you're not quite in presentation mode yet from my end, Erin O'Malley. And
should be now.
Yep, you're fully there. Thank you for that. And it's all yours.
All right. Hi, everyone. I'm here to talk about the court case at issue, which is Braidwood v. Becerra, who is our Secretary of Health and Human Services. So just to get started, I'm going to kind of highlight the different agencies and kind of legal issues at hand right now. So first, we're going to start with what is the USPSTF, which is the agency at issue right now. And this is, for those of you who don't know, the United States Preventative Services Task Force. It was actually convened in 1984 to give guidance on the evidence base supporting certain preventive services, mainly to doctors and healthcare systems. So it's really been around for a while. And then in 1999, the Agency for Healthcare Research and Quality was directed by Congress to convene and appoint members to the USPSTF and to support the independent task force's operations. So this is an important point, that how the task force works and is appointed right now was actually directed by Congress. And it was set up this way so that the recommendations would all be done by an independent scientific body. And then in 2010, as most of us probably know, the Affordable Care Act linked these recommendations to health coverage requirements under certain circumstances. So just some examples of USPSTF recommendations for heart health. These are the ones that AHA, or the American Heart Association, I know there's another AHA, is most concerned about, include counseling about healthy weight for pregnant patients, aspirin use to prevent preeclampsia, which is high blood pressure during pregnancy, even screening for preeclampsia more regularly in pregnant patients, hypertension screening for adults, and other healthy diet and physical activity screenings, and also statin use for prevention of cardiovascular disease. So these are pretty big ticket, pretty expensive down the road, and really important preventative services that AHA is concerned people won't be accessing if the cost sharing is reestablished for these services in these plans. So how does this really tie into the Affordable Care Act? In the Affordable Care Act, there's a preventive services coverage mandate where there's a requirement to cover USPSTF A or B level recommended services, along with some recommendations from other agencies, which we'll get to in a second, with no cost sharing for patients, because cost sharing can be such a big barrier, as my other co-presenters are going to talk more about the math and the numbers behind that. You don't want a lawyer to ever be in charge of the math and the numbers. The coverage that's impacted is going to be private, non-grandfathered. So before the Affordable Care Act was implemented, some of those plans aren't impacted. So those plans, which are most employer-sponsored plans, actually Medicaid adult expansion group plans, so any plans that are created because of Medicaid expansion being implemented, those plans also are impacted by this. And then USPSTF recommendations are also covered in kind of a similar manner in Medicare Parts A and B. And then traditional Medicaid is encouraged to cover these services with financial incentives for states. So that's just really all of our health insurance system, even some parts of the VA, not to get into the VA when we don't have to. All of it is tied to these recommendations now. And there's been a lot of really well-proven impact of this coverage mandate on patients. And I can share slides after this, but this is a great quote with underlined links to studies on to kind of support everything in it. But the preventative services coverage mandate is now one of the ACA's most widely recognized and popular benefits. It reaches about 224 million people. It's led to increased use of prevention, improved health outcomes, and reduced racial disparities in access to care. And that's a finding by a team at Georgetown. So this case that we're talking about right now is Braidwood v. Becerra. It actually started out with a different name. It was first filed in March of 2020. So if you kind of feel like, haven't I been hearing about this for like 3 or 4 years? Yes, you actually have. So it was a case filed by Braidwood Management Co. So filed by an employer or group of employers because they have standing to challenge the employer coverage mandate. And at first it went to the federal district court in the Northern District of Texas. And there was a ruling in September that just related to the parties in the case. Most of that ruling was related to the Religious Freedom Restoration Act claims about the employers not wanting to cover certain services that they believe is a burden on their religious exercise. And then you might have started to hear even more about this case in March of this year, because that's when the judge in the case made a ruling on the broader remedies that the plaintiffs, Braidwood and Co. wanted, which implicated all health plans throughout all of the United States. So at that point, the practical impact on coverage was it struck the requirement to cover USPSTF preventative services issued or updated after 2010 with no cost sharing. So the big takeaway on the legal front is that part of the preventative services coverage mandate was invalidated on two different constitutional grounds. So the first is the First Amendment. So is coverage of certain preventative services, in this case, PrEP, for patients who may be at risk for HIV or AIDS, is that a burden on religious exercise for certain employers? And then there's also, and this is kind of the weird tangly one, an appointments clause issue, which is whether or not the USPSTF members are technically officers of the United States who need Senate confirmation after appointment. So you can see why that would be an issue in terms of the original purpose of this body being independent. If people go through Senate confirmation, there's some politics involved, there's a lot of potential for money to influence, and there are certain preventative services that if people who don't need them receive them can actually be harmful to patients, which is why it's so important that the USPSTF keep recommending and keep updating their recommendations too. So that's the real issue here, is whether or not these people are technically legally allowed to operate in this way, the USPSTF members, and what this judge said was no. So not only does it kind of get at all of the preventative services coverage, it also gets at the core value and the core kind of operation of this agency and any other laws, federal or state, that it impacts. Because some states will say, oh, well, we're going to cover in non-ERISA plans, USPSTF A and B recommendations. So is that impacted? So that's kind of every health lawyer in the country has been kind of looking into all these questions, depending on how broad these rulings have been. So this is kind of the meat of the case at the federal district court level, which just kind of finished. I'll also note that we are looking at another case before I get into what Braidwood's doing now. The Loper case, which used to just be about environmental protection regulations. It's been brought in by the Supreme Court now to concern any agency authority generally to interpret its authority as given by Congress. So we're also watching the Loper case in terms of agency authority to act. So that case, if it's not on your company's radar, should be in the next Supreme Court term. And that's also kind of in this appointments clause vein, something that could really impact what agencies are able to do and when, and how involved Congress needs to be to pass policies, for better or worse, as I'm sure you're all keenly aware too. So what now with the Braidwood case? The Fifth Circuit Court of Appeals, which is based out of Louisiana in New Orleans, just granted a stay or a hold on the district court's ruling while the appellate process goes through. So this means that right now the preventative services coverage law is still in effect. So there's been no change to the law now because the circuit court put a hold on the district court's ruling going into effect. There is a deal between the parties where the Department of Justice is not going to enforce this against the specific plaintiffs to the case, but it will not impact anyone else. This appeal is going to take a while. Like the briefing schedule, which is just the written arguments to the court, goes all the way till November. So we're still anticipating needing to take this to the Supreme Court, and we'll probably be doing webinars about this case until 2025 or 2026 even. So it could be a while, and a lot of kind of back and forth on what the policy is that employers will need to be watching, unfortunately. Another really important thing to know is there are now cross appeals in the case, which is when the plaintiffs don't really like how, even if it went their way, the initial ruling went, and they want even more. So at the appellate level, they are kind of positioning it so it could strike all preventive services coverage requirements under the Affordable Care Act, including those from the Advisory Committee on Immunization Practices, so vaccines, and the Health Resources and Services Administration recommendations that relate to care for women and children specifically. So these agencies weren't in the original Braidwood case, but now they're saying, well, if you said this about this agency, what about these two? So that's another thing this stage of litigation will decide, is just how broad this case will be and just how much of our coverage landscape will be implicated. So right now, AHA and our partners are committed to continuing advocacy to protect this policy and any other policies implicated that we believe, based on science, contribute to longer, healthier lives for all. And if this mandate is eventually invalidated, employers and states, if we're talking about Medicaid plans, will have a lot of decisions to make about both coverage and how do you go back to incentivizing utilization of preventive services if it's not required by law, and if it would require extra negotiation with your insurance plan, or all of those other questions that people were having to grapple with, looking at the science themselves before the Affordable Care Act was passed. So that's just kind of background on the case, kind of what's going on. Still a lot in flux and a lot that we're watching. As that's not the ideal way to have to end what I'm talking about, but I'm going to pass it back to Karen now to go to Rachel.
This is a great way to start the webinar and set the stage. Erin, thank you so much. So as we bring on Rachel to get reactions, we're going to tee up the second poll. Insurance payers, employers, and the private sector generally have a vital role to play in setting health policy related to what services are covered. Do you agree or not? Folks are already weighing in. And so Paul and Rachel, I'll hand it to you.
Yeah, let's encourage our participants to get us up to 80% this time of folks who weigh in on this poll. As we're waiting for those results, Rachel, you've published a lot in terms of issues related to insurance and access to insurance and health promotion more broadly, of course. It seems the Leapfrog group at the national level in Minnesota, there's something called the Healthcare Buyers Action Committee. It seems like the employers have a history of mobilizing with some voice around what they want to pay for and what they don't want to pay for, and how they want to be proactive about quality and access to care. How are you seeing those trends? Are you seeing employers more than in the past trying to brace for things like this and have a voice, or are you seeing less of that, or what general trends are you witnessing?
I mean, I think employers certainly have a voice at the table, and I think they're certainly bracing for this decision because it does relate to, the benefit package that they're offering their employees. But I think in general, healthcare costs are expensive, and that's something that they always have to keep in mind. It's it's an important benefit for them for keeping their employees healthy, for retention, for their families. But it certainly is something that is top of mind because of the costs associated with it.
Yeah, here's our results. You are in full agreement with the participants in this webinar, and I actually looked at our participants list just now. Very influential folks showed up to listen to you guys talk about these issues. So I think you're helping us educate the right people here for sure. But look at this. Almost 80% are between agreeing and strongly agreeing that the private sector has an important role to play here. A few are disagreeing and not so sure about that. So we're going to come back to this. Erin O'Malley, thanks so much for teeing up this tension between the science community and the public policy community and the politics of all of that. I think that's where it gets a little dicey, Rachel Henke, for employers to find their space, and let's explore that together. But your thoughts on this decision so far?
Yeah, thanks. Thanks so much for inviting me to be part of the panel here. This is really really interesting discussion. And I'm just going to make a few points, I think, related to healthcare insurance and healthcare insurance design and how that relates to healthcare utilization. And just to set the stage, of course, all opinions and perspective I reflect are my own, and a lot of them are somewhat informed by the high deductible plan that I had for the last few years. All right, so a couple of the points I want to make. Again, you're not missing anything. I don't have slides. I'm just going to be talking and hopefully sharing some key points from what I've learned since I went to graduate school. There is a relationship between out-of-pocket costs and use of healthcare services, but that relationship is very nuanced. So if employers are thinking about, hey, we really want to get everyone to do these preventive screenings, so we, even if this decision goes through, we want to make sure it's totally covered, and that's going to be the panacea for getting everyone the preventive services they need. I don't think that that's quite the case. There are many other factors that do relate to utilization of healthcare services that employers actually might be able to also play a role in. So I'll talk about out-of-pocket costs, use of healthcare services. I'll talk about other factors that may be increasing and keeping people from using preventive services like screenings. And then again, beyond healthcare insurance, I think, as we all know, employers play an important role in the healthcare, the health of their workforce. And right now, as we're going through a time where there's a lot of burnout, a lot of mental health concerns, there are certainly a lot that employers are focusing on to keep their employees healthy. So talking a little bit about that as well. So first, one of the first things I learned in graduate school was about the relationship between out-of-pocket costs and healthcare utilization. So you might think it's pretty straightforward to be able to understand and measure the relationship, okay, between out-of-pocket costs and healthcare utilization. You look at a group of people that has a very generous health insurance plan, and you compare their healthcare utilization to people who have a higher co-payment requirements, and you say, okay, well, what's the difference in healthcare utilization between these two groups of people? And that'll tell me, okay, well, that's the importance of keeping co-payments down. But in reality, I think, as we all know, people decide on their health insurance plan. There's selection that goes into their decisions of whether to take a generous plan or a plan that has a higher premium cost. And a lot of those decisions are about their known understanding of their healthcare needs. So if you look at these two groups and you see that the more generous plan does have more preventive screenings and more healthcare utilization, you can't attribute that to the generosity of the plan. You can't attribute that to the fact that they have lower co-payments. So, this has been really of interest to health economists for years, as since there is this what they call adverse selection into healthcare insurance plans, how can we tell what the impact of out-of-pocket costs is on healthcare utilization? And so one of the first studies that I learned about was the RAND health insurance experiment. And this was conducted way back in the 70s and early 80s because they really wanted to understand this relationship because it informed, what type of benefit design should payers be promoting. So in order to get around this selection of, this group has more health concerns than the others, they actually conducted a randomized controlled trial, which is really the gold standard way of being able to balance two populations on observable and unobservable factors. So they randomize groups of people into higher cost sharing plans and plans that had no cost sharing requirements. And because it was randomized, these two groups should be equally healthy. And so any differences in healthcare utilization would be associated with the health insurance design that they were randomized to. And so they followed this population for multiple years, and they found that indeed there was a relationship. So they saw that the individuals and families that were randomized to have more generous healthcare coverage really did use more health in health care, and the individuals randomized to having more co-payments, they had less health insurance or health care utilization. And so that really did prove once and for all, at least back then when things were slightly different, there wasn't as many health systems, there weren't these high deductible plans, but it did prove that there was this relationship between co-payment and healthcare utilization. But some of the nuances they learned in this study, I think, are also really important to think about when we think about, what does this decision mean for, increases and decreases in preventive services if we take away this co-payment, if we take away the 100% free co-payment for use of preventive services. So some of the nuances were that, people were very, people reduced their use of healthcare use, but it wasn't just for certain types of services. So it was sort of across the board. So people reduced their hospitalizations, they reduced their physician visits, they reduced their dental visits, prescriptions, mental health treatment. So it wasn't, people weren't sort of deciding this is very high value healthcare services, I'm going to keep this even though I have a high copayment, versus this one is less high value, so I'm not going to do this. So there was sort of a decrease across the board in healthcare utilization. And they also found that it also led people to, the reduced use of services was primarily driven by participants deciding not to initiate care. So once patients entered the healthcare system, cost sharing only modestly affected the intensity or cost of an episode of care. So I think what this tells us is once you have a primary care provider and you have that relationship, and if they are informed about screenings and trying to encourage its use, that might go a long way to you getting your screening, even if there is a modest copay, for example. In general, the health insurance experiment, which this was called, showed that cost sharing is really a blunt tool. So economic incentives by themselves do not lead necessarily to clinically sensible increases in service use. So I thought that was really interesting. Again, it's somewhat dated because it did happen in the late 70s and 80s. And I think the environment now with healthcare systems and our understanding of patient-centered medical homes, and there's a lot more sort of value-based care. I think there might be some differences in the results if we were to conduct it again today, but I think it's still very meaningful in establishing that relationship. So back to the talking more about the ACA. So when we think about the preventive care provision, and so, back when it was made, I think my understanding is that, it was our use of preventive services across the board is not ideal. I think it was like there's a lot of room for improvement. Let's just say that. So where did we go after ACA went into effect and we had preventive services were covered at 100%? Did that really increase preventive services use? Did we see that? And I think Erin showed that there is some evidence that provision did impact preventive services use, but it's a little bit more nuanced than that. Like it's not across the board with all of the screenings. And it's not across the board for all populations. So colorectal cancer screening increased for privately insured, but not breast cancer screening or Pap tests. There's an increase in Medicare wellness visits, but there are some other, it wasn't sort of across the board like, wow, this is amazing. This is exactly what we needed. We needed to see this, and we needed to reduce the co-payments, and then we're going to see a lot more use of preventive services. It's a lot more nuanced than that. And I don't think anyone would be surprised by that. There's a lot of factors that goes into using healthcare services and specifically to getting preventive services. So for example, like I think primary care provider has a very important role. So people that have insurance and even have a generous coverage, if they don't have a primary care provider relationship or a primary care that's acting as a medical home and encouraging preventive screenings and helping them set up appointments, for example, for colorectal screenings, they might not get preventive screenings even if they have a zero copay requirement. There's medical mistrust that's keeping people from using the healthcare system and even from getting some of these preventive screenings. And sort of similar to that, there's a lack of clarity about what screenings are appropriate for which populations. There's always new scientific evidence coming out and new nuances to the populations where it's appropriate to get screening and not. And I think some of that lack of clarity does does lead to some changes and shifts in use of preventive services. The next thing I wanted to just cover was from the healthcare industry's perspective. There's a really interesting article in 2019 by CDC authors, which wanted to understand from the healthcare industry's perspective why the use of preventive services is low. And I thought this was an interesting perspective that I, as a healthcare provider, don't have. So I was interested in what the experts they interviewed had to say, and they talked about how healthcare providers, yes, they obviously preventive screenings is on their radar, but it's not necessarily their first priority. Their organizations determine priorities based on financial and economic considerations. And for healthcare providers, some of the higher ticket items are, maybe more of the not preventive screening, but more of the chronic care and acute care services that they offer. And so there's still a lack of financial risk for outcome measures associated with preventive care, and a concern that payment models weren't yet really influencing the uptake of preventive services. So I thought that was really interesting, because obviously the healthcare providers have a role to play in encouraging preventive services and making sure the patients that see them for primary care or even specialty care are encouraged to get preventive services. I guess the last point I wanted to make was about employers' role, as a payer and also as an employer with a workforce that, they have influence over via communication channels and via the culture that they set as an employer. So as a health insurer, employers obviously do have, particularly self-insured employers do have a role they can play in establishing obviously the design of the health insurance plan, what's covered at what levels. There's a lot of really cool innovations employers are doing in insurance design. So even beyond preventive services, they're thinking about different ways of incentivizing use of chronic care, high value chronic care services, medications that are really important for people to take to avoid hospitalizations and emergency department use. And so a lot of these insurance design innovations are sort of within the umbrella of value-based insurance design. And the concept is really to use the insurance design, the benefit structure, and some of the incentives to the beneficiary or to the patient to increase consumer adherence with recommended care guidelines. And there's a lot of really cool things that is going on in this area with large employers. So it's beyond preventive services. Again, it's with encouraging use of chronic condition services, important for employees with diabetes, for example. And then even Medicare is doing a test of different insurance designs within its Medicare Advantage program. They have a value-based insurance design test that they've been conducting for a number of years. And they're really trying to see if they can really use the benefit design to encourage healthcare utilization in a smart way, if that can really be effective at getting higher utilization of these high value services. So employers certainly should think about this and think about how insurance benefit design can help their workforce. But beyond that, employers have a huge role right now with all the burnout that people are experiencing, increased mental health concerns during and after. I don't know if we can say after the pandemic, but there's a lot of going on with workforce health, and there's a lot that they can try to do as the workforce changes and the setting in which we work changes and the time in which we do work changes. So I think there's a lot on employers' plate, but importantly, if they can strive for a culture of health where people can feel comfortable and feel empowered to take care of their health, take on healthy behaviors such as physical activity and eat nutritious food, and also to, again, make sure that they're up to date with the screenings and the preventive services they need. There's a lot that employers have on their plate in their area. So I think that's where I'm going to stop, and hopefully that's a nice segue to Erin Seaverson, who will be talking about what employers are doing more specifically.
It's a perfect segue, Rachel. You don't even need me anymore. It's the perfect segue to bring Erin into the conversation. And we're going to tee up another poll about status of your investments in health screenings in your organizations or those you work with to help start the conversation.
And as we're waiting for those poll results, Erin Seaverson, you've written a lot, studied a lot, researched the effectiveness of health coaching. And we're going to talk in some future polls about trends we're seeing in mental health versus physical health generally. I was trained in as a health coach. I know one of the things I was evaluated on was based on gender or age or chronic conditions, whether or not during the coaching call, I made referrals into preventive screening or made consumer education comments about their eligibility for or their up-to-dateness of their preventive services guidelines. And that was independent of whether or not that's what the call was about. If they're a smoker or someone working on weight, if they meet these criteria, I had to make those referrals. I was happy to do that, of course. What are you seeing in terms of the use, building on Rachel Henke's last point about the role of the employer here? Health coaching is, as a sort of a consumer advocate and in consumerism, are we seeing trends with more employers using health coaches and getting good utilization of health coaches, or less so given other tech options? What are you seeing?
Yeah, I feel health coaching is one of those evidence-based practices, solutions that employers have had a lot of success. Individuals who connect with a health coach have had a lot of personal success in managing chronic conditions, in making improvements to their health and their well-being, and that translates into what we can show for population level impacts. It is over time, we see interest ebb and flow, the focus of coaching. Is it condition management? Is it lifestyle management? Is it mental health coaching across a spectrum of care, spectrum of severity, if you will, ebb and flow. But I would generally say it is a constant. It is an area that we are constantly talking to our clients and that we partner with, and it tends to be a solution that again, I would consider it to be a constant.
Yeah, got it. Well, and it appears that health screening is somewhat of a constant, although there's a good 30% here, Erin Seaverson, who are saying they're seeing significantly less or somewhat less of employers investing in health screening. Love to hear your thoughts on that. Not very many, about 15% are saying more or somewhat more, but generally this seems like it's still a pretty common core element of a health and well-being offering. So let me turn it over to you to reflect on Braidwood in the context of what you're seeing.
Thank you. And again, happy to be here. So I was asked to represent what we're seeing in the industry in terms of uptake of biometric screenings, how we might typically refer to them as an avenue of health assessment to understand the needs of a population, to support individuals in identifying health status, to help them get connected to the right resources, to meaningful interventions, whether that be clinical care, whether that be coaching, for example, to prevent onset of condition. In general, from our experience at WebMD and also industry, we typically see about 40% of large employers offering biometric screening services. I would say that at the onset of the pandemic, so as we think back to the last few years, in 2020 specifically, there was a significant drop in people accessing the healthcare system for preventive care services. I think we have all experienced that, probably personally, organizationally. We saw it reflected in our populations. These gaps have persisted. We still see lapses in care, people not going in for their annual well visits or preventive exams. Thinking specifically about biometric screenings or screening support services, again, in 2020, employers were hit really hard. We were all going through this massive period of disruption and trying to figure out how we can best support our populations, and recognizing that strategies had to pivot really quickly because most of our employees were no longer on site. So how can we best enable them? So what we saw was, especially for organizations that had implemented screenings on a regular basis, There was a full suspension or an elimination in some instances of screening support. There was a reduction or sort of a reallocation of an incentive strategy. There was some creative solutioning around how to support biometric screening services. So, we actually had an organization that we had worked with who regularly would implement on-site screenings, and they were able to preserve those by shifting and getting creative and doing more drive-through screening. So we saw a lot of innovation just in terms of helping to meet people where they are, continuing to support their populations in whatever way they could related to screenings. We're now seeing more of a right sizing, I would say, where more employers are reincorporating biometric screening services into the scope of their well-being strategies. It's been a slower return to on-site services, but I also feel like this is very consistent or reflective of the workplace trends that we're seeing, where we have much higher percentages of individuals working virtual or more in hybrid capacities than what we were prior to the pandemic. So again, getting creative in terms of how these services can be supported. We're seeing more use of more home test kits. So bringing these sorts of preventive screening opportunities into the home, meeting employees where they are. We've also seen budget constraints. So as we think about how to continue to support employees and their well-being journeys, and we have this pool of money that continues to be challenged for a number of different reasons, thinking creatively about how to maximize investment in certain areas. So again, some of that is also shifting where resources are allocated. It may still be for screening services, but instead of on site, it may be other avenues that organizations are exploring. We're also seeing expansion of the tests that are being offered. So those that are perhaps more diagnostic in nature, for example, colorectal cancer screenings or PSAs, kidney function tests. And I think for employers, it comes a question of great to be offering these services, but how can we support individuals once they have those results to guide them to resources, to provide them with the referrals so that they aren't left with questions of what do I do now that I know these things about myself. And I think, again, as we consider where we've been the last few years, biometric screenings and supportive health assessment really feel very important now as we consider ease of access to vendor partner services, referrals, helping to reduce that gap in care, ensuring employees have access to understanding what their health needs are, raising awareness, helping to support prevention of chronic conditions, early identification of disease situations. Let's see here. The other thing I wanted to raise too is, screenings have typically been very focused on an individual's physical health. So as we think about the broader notion of well-being, we know, and we talk in the industry, that the focus is much broader than that. And again, coming out of the last few years, every conversation that I've been in, every conference, every webinar, mental health is part of the agenda in some way, shape, or form. And I think that's very much so at the forefront for employers where, yes, physical health continues to be important. It will always be important, but we recognize that the concerns around mental health, the needs of our employees really are elevated in that regard. And so we are seeing employers increase their level of investment, increase their focus, really making that a strong focus of their well-being strategy. A lot of attention being put to training, support services for managers, so equipping leaders across all levels of the organization. So not just enabling employees and making sure that they have the right resources, but also equipping individuals across the full range of the organization to support each other in addressing mental health, being able to talk about it, normalizing the conversation, for example. I think those are my main points as it relates to screenings and how it's evolved over the last few years and the continued importance of them.
Yeah, that's all terrific, you guys. So let's all jump back on screen and we'll keep the conversation going by keeping some polls going based on the things you guys have already talked about. So Erin Seaverson, you reflected on how you're seeing pretty constrained budgets, even in some cases shrinking budgets. Let's ask our participants, assuming a zero-sum game here, we don't have new money to spend in terms of health and well-being, and if not even insurance coverage, assuming a zero-sum game, what are our participants' views here about the use of resources in mental health compared to physical health? Erin, I think you could attest to the fact that HERO is seeing a lot of shifts, certainly in our learning agenda, relative to mental health, especially pre and during and post pandemic. A lot of attention on health equity, including mental health issues there. So we're asking here, should it be balanced, resourced about equally? We should go ahead and shift more to mental health, or we need more in physical health. Before I end that poll, Rachel, Henke, over to you. You just wrote a pretty big section of the Knowing Well, Being Well section of the American Journal of Health Promotion on mental health support during the pandemic. You're an expert in value on investment as well. Do you think the mental health, assuming that there is a shift in the mental health area by the private sector, is that being held to the same standard in terms of some expectation of a return on investment, or is there a different value proposition that's accompanying shifts towards mental health compared to physical health investments?
No, I think there's certainly a return on investment argument to be made with investments in mental health. You know, there's a lot of research has been done looking at, for example, depression and work productivity and work-related absences. So I think, you know, in my research with Ron Getzel, for years, depression was one of the, you know, the high cost services. So people who were at risk for depression were associated with, you know, had higher healthcare costs in general. So I think there certainly is a return on investment argument, but I think there's also just, you know, I think it's more than that. I think it's, I think when there is, I think mental health there's obviously people who have mental health conditions, mental health disorders, and that they've had for, you know, for particularly for possibly a number of years, but then there's also concerns about burnout, which are related to stressors that individuals who are working don't feel like they can have any relief from. And I think that that is something that is exacerbated during the pandemic. And I think it's something that is not only because of return on investment, but I think employers are concerned about you know, burnout, because it does sort of create some splinters in their care teams, some inability to bring teams together if there's more turnover, if there's less sort of employee morale. So I think it's almost more than return on investment, and it's more about sort of a culture that they want to uphold that's related to their interest in putting more investment or resources into mental health.
Yeah, to our Erin's, you're seeing the results here. 75% are still in favor of balanced proposition, equal investments between mental and physical, with 25%. That's a good number of our participants saying they're okay with seeing more shifts towards mental health. Erin O'Malley, given you work for the Heart Association, which at least historically would be quite a champion for physical health and taking care of one's heart and body. How do you guys see the mental health overlap, especially as a policy thinker, relative to how you balance things out and improving health overall?
Yeah, I mean, we obviously know that there's a lot of impact on your physical health, especially your cardiovascular system, if you have mental health issues or consistent stress. Whether and how to engage in certain policy efforts on that front. There's a lot of organizations that have really specific expertise on that front. So we do try to defer to them on what's best for patients and looking at the science. But it's an area of interest for it. We've been looking at it more and how we can kind of loop it into some more of what we're working on for sure. And I'm getting notifications now on my work computer for our employee wellness mental health seminar that's coming up this afternoon. So they've been making investments as an employer as well. So, but yeah, it is complicated for age. I mean, everything impacts your heart, so it is a little bit hard to assess which things to
right. You've heard of this mind-body connection thing. Even cardiologists, they talk about the
So, but yeah, it's a really interesting question, and it's good that a lot more people are investing on that front.
And
so Braidwood, as you described it, Erin O'Malley, has a lot of similarities with the culture wars generally that are going on related to things like women's reproductive rights, trans people's rights. The PrEP, I think, was especially what got a lot of people's attention, PrEP being the pre-exposure prophylaxis for HIV prevention. So that would mean that some religious groups are saying, well, I am not supportive of the gay community and their right to have money spent on their bad habits. So in that context, what should the private sector do? I mean, the typical employer is loath to get in the middle of political issues. They obviously want to have everyone be happy, but tell it to Disney and the Florida governor. Sometimes it just doesn't work. So let me show you the results of this one, and then Erin O'Malley, have you reflect on how a big deal organization like the Heart Association decides how to weigh these tensions between politics and science. Of our participants, nearly 50% are saying employers should just follow the science and stay away from politics. But we have a good 40% here that says employers need to engage in policy making, including weighing in on the culture wars. And then 13% saying, we need to stay neutral. You guys talk about that, especially you policy thinkers, what lines you don't like to cross in terms of some of the religious dynamics, the cultural dynamics, the political dynamics behind what Heart is advocating for or against?
I mean, we always follow the science. I mean, have a lot of scientific statements on, medical decisions being between people and their doctors. So, I mean, when to get into the fray, I mean, all organizations have different metrics for that. And when they know they'll be more helpful versus less helpful, and whether they think it's more of kind of a battle for the soul of the organization or for their specific employees. I think that's another consideration that is sometimes harder to make. So I can't speak for the Heart Association on either of those fronts, but we do, that's our bread and butter, is following the science when we can. And there is a lot of science behind most of these kind of culture wars issues. So that's our position, is that we follow the science. But that we don't, I mean, having a position versus engaging on things is different too. So that's kind of, and every organization has differences of, if we have Medicaid to protect, then we might not get as involved in other things because we only have so many resources as well.
Yeah.
So we have a lot going on.
Yeah, Rachel, Erin, let me put you on the spot. Would your organizations, do they weigh in specifically on issue, let's say the Dodd decision? Did they take a point of view that was public on women's reproductive rights? Rachel, let me start with you.
I'm not sure.
I know you're new at the Lewin group, or would Lewin have a point of view on PrEP? Would they?
I wish I could.
Yeah,
I wish I could respond. I'm actually not sure about that. Yeah.
But all right, Erin Seaverson, I jumped on WebMD's website and read about PrEP. You certainly teach consumers about the scientific effectiveness of pre-exposure prophylactics in HIV. Do you pay for it for WebMD employees? Do you advocate for it and tell them that they ought to know about it and use it?
I think education and awareness is very important. And so that would be generally the approach that would be taken. From a Do we take an official position perspective? My answer would generally be, it depends. I mean, we do what we can to support our employers or our clients who are coming to us with questions, and we would approach with evidence and insight from an employer perspective or from a health plan perspective, but less opinion perhaps, and more like interpretive guidance that aligns to the science, that aligns to the research.
Yeah, got it. Hey, Karen, I think we have time for just one question if you've got something on your end.
We do have a question from Michael. Are there legal concerns for companies when offering biometric screenings on site to their employees? Does it jeopardize wellness program status? Anybody want to take that?
There's almost always legal
Erin,
concerns.
please, go ahead.
No, I mean, I was going to give a very broad, there's almost always legal concerns with biometric anything and anything that you're doing on your employer campus that's not specific to the job. So what that could be depends, some of it could implicate the Americans with Disabilities Act, depending, some of it can implicate other federal laws, state laws even. So the specifics would really be pretty dependent, which is the worst thing for a lawyer to say, but that's what I'll say. Pass it over to other Erin.
I actually think that was perfect. And thank you so much for jumping in on the policy side. As it relates to, does it jeopardize wellness program status? That's also really hard to say. And we think about biometric screenings as more than just a data collection mechanism. It's a really wonderful opportunity to promote the broader well-being strategy, to get individuals connected to programs, to resources. So it can also have a very positive impact on the reach of the well-being program.
Rachel, we chatted about this first poll, and we seem to be in agreement that you and I have been around long enough that we saw, especially the explosion of disease management for a while, being something of a gap filling behavior by employers. They weren't seeing from their healthcare provider systems sufficient or adequate attention to really getting after things that are costly for employers. And so we speculated together, is Braidwood yet another example of health systems being the bearer of changes in both policy and reimbursement and access to care compared to the employer's role? I think we were affirmed in this final poll here, Rachel, that again, our biased audience of folks who are health and well-being experts saying almost uniformly that no, the health system doesn't have it all figured out yet or covered or reimbursement wise. So what does that tell you, Rachel, in terms of back to our question of advocacy and the employer's role? Are you, in light of Erin Seaverson's observation that it's not like these budgets are expanding a lot nowadays and people are making tough choices, what kind of choices are you seeing them especially focus on?
Well, I really thought the idea of employers serving as a bridge is really important. So I think particularly for people who don't have those relationships with the healthcare system or with a primary care medical home, which can be really effective if you have that relationship. If you are connected to services, if you do a biometric screening and are able to get in the system to be directed to a high value provider, I think that is really helpful. And I do think that the workplace can offer that either by sort of, direction to high value providers, but even like, this whole, social connection, learning from your coworkers, what has helped for them, I think is really important, given that you have the same insurance plan. So I think, serving as a bridge is important, but also even in the mental health, we have, employee assistance programs are pretty typical benefit offerings. I think that can be a way of individuals seeking, if they're seeking relief of a stressor, that can help them sort of see that help is available. They don't have to bear that burden themselves. And I think employee assistance programs can be a low barrier to entry. Usually there's a phone number you can call whenever, and then that can help you really see that there are, providers in the community that might be able to help if you have a health concern. And then that might eventually lead to a really good relationship with their primary care provider that will sort of enable you to have all of the preventive services that you need.
Terrific. Well, thanks so much, all of you. I can assure you and our attendees that we will stay tuned into as progress as this develops. Probably have you all back at some point when there is movement or decision of some sort. And if Erin, if there's an opportunity for a consensus comment or any kind of work along that area, HERO does have an ad hoc policy committee and would love to, of course, partner with the American Heart as we've done in past comments and consensus statements. So let us know if we can be, supportive in that way. You've given a gift of education and information to our attendees. Thank you so much. Erin Seaverson, especially on your birthday, you've given us a gift instead of one to you. So happy birthday. Next week, I invite all of our HERO members to tune in. We have a HERO members only webinar on June 21st. It will be looking at the 4-day work week, yay, nay, or it depends, with scholar Juliet Score from Boston College and our own Tammy Simon from Siegel on a HERO board. And I forgot to name that in your bio, Erin, that you're our newest HERO board member. So anyway, lots to throw at you. Hope to see you next week, June 21st, for our HERO members. If you're not a member, of course, we'd love to talk to you about membership opportunities. Until then, we are adjourned.